Good afternoon to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. N. Sundari. Ma'am is MBBS, DNB, Ops and Gynecology, PGDMLE, consultant at MS Ramaya Memorial Hospital, Bangalore. With the help of Ma'am and her wonderful insight, we will be taking a close look on today's topic, which is management of third stage of labor. Now, without any further delay, I would like to welcome Ma'am at our forum and would like to hand over the session to her. Over to you, Ma'am.
Thank you, Sriyan, and
Thank you.
good evening for all the viewers, and thanks for the entire IJCP group. Okay, this is I don't know why she has chosen this topic, but I congratulate her for choosing this topic because this is a very, very important topic. Though it may be for speaking about it may not take much time for us, but it's a very, very important topic. So we'll go through next few minutes what we need to know about it. Some authors said about the third stage of labor, this is a unforgiving stage of the labor, and in it there lurks a more unheralded treasury than in both the other first and second stage of labor. That means it's a very, very simple, but at the same time, very dangerous stage of labor because a normal delivery can turn into a big disaster. Even though sometimes we may lose the patient also. That is the peculiarity of third stage of labor. Now, this is under these headings, I'll be going through this topic within the given time. Now, the definitions. This labor, as we said, we used to know it used to be the three-stage labor, stage 1, 2, 3. Now, one more stage is added, that is the fourth stage of labor. All of us know that first stage of labor is the starting of the contraction, that is establishment of the labor up to full dilatation of the cervix. Second stage is in that we have two phases, early and active phase. We used to call it as a latent phase before, and then the active phase when the labor establishes with a regular contractions. And there is an effect of this contraction on the cervix like effacement and dilatation. Then we say active phase of the labor. Now the second stage when we come, this is exactly what happens is the full dilatation of the cervix to the delivery of the fetus. Now, this fetus delivering is the second stage. After the delivery of the fetus, everybody will be happy, everybody is relaxed. A newborn is good, cried well, so we tend to relax. We try to forget, we leave the third stage maybe to the juniors or maybe to the staff nurses, experienced labor room staff nurses. There we get into problems. That is the delivery of the placenta. Though it is a easy delivery of the placenta, doesn't have the tension like a baby may be hypoxic if it is delayed, second stage of labor. All that is okay, but this can cause a harm to us. A lot of complications can occur in the third stage of labor unless we manage it effectively and correctly. Now, the fourth stage of labor, now it is 1 to 2 hours after the delivery of placenta. It is seen over the years that this is the time usually delivery placenta is delivered. We leave the patient, all of us go, and she will be in a pool of blood. Nobody recognizes it in the ward. And then she can throw a fit and she can go in for a shock. These are the things which have been diagnosed later. So now the fourth stage of labor has come in. That is 1 to 2 hours close monitoring of the patient as we are monitoring in all the stages of labor so that we can prevent any untoward events happening to the patient. Now, going to the physiology of the third stage of labor, what happens once the baby is delivered? Uterus starts contracting. When the uterus starts contracting, what happens is the surface of the uterus comes down, but the placenta cannot shrink as uterus shrinks. Uterus is a muscle, so it can shrink and contract. So what happens? The placenta, which cannot shrink, has to get separated. In the bargain, there is a tear on these vessels, in the spongiosa, deciduous spongiosa. and the blood collects here. Because of the blood collection, further separation of the placenta occurs and placenta comes down, descent of the placenta into the lower uterine segment first and then into the vagina, and then it is expelled and the uterus becomes empty. These are the process of placental separation and expulsion. Now, how it happens, as I told you, uterine contractions decrease the size of the uterine cavity. Placenta cannot decrease, so it comes down. Placenta has to get separated, tearing of separation of the placenta. And spongy layer of the residua basal is also teared. So retroplacental hematoma due to tearing of the residual vessels and the placental separation starts. It occurs anytime within 15 minutes to 30 minutes after the delivery of the baby. It occurs. If it takes more time, sometime it do take more time, then we call as delayed third stage or prolonged third stage of labor, we call it. This is the way it gets separated exactly. This is the hematoma. The placenta, it pushes down as the hematoma, it increases, it pushes down the separated placenta. So the uterus contracts here after that. That's a protective mechanism so that the blood vessels seal off, so no further bleeding will be there. Now this is in the lower segment and this is getting separated and then comes down like this. Probably then it will get expelled. Now, the signs of placental separation, what do we see on the patient? Clinically, what do we, this is physiology, we know. We don't go into see in the uterine cavity. Now, what happens to us? How do we know placenta has got separated? The fundus of the uterus raises above the umbilicus. Uterus becomes very firm and discoid. Fresh vaginal bleeding will start. And what is we teach to our students is extravaginal lengthening of the cord. This is important because see, once the baby is separated, placenta, the cord is clamped near the vulva. Now this vulval cord, because this will help us to recognize the lengthening of the umbilical cord. So at the vulval region, you put a clamp for the cord and then see how the lengthening, where it comes. The clamp is here. That means this much of lengthening of the cord. That means the placenta has descended down. That's a sure sign for us to say that the placenta has separated. If you push the uterus up suprapubically, put not the fundus, suprapubically, put your fingers and push the uterus away, but this placenta will not recede back. That means it is no more in the fundus of the uterus, it is separated, maybe it's in the lower segment or even it is in the vagina. This is, and then the fresh bleed. This is what we used to tell our students, fresh vaginal bleed occurs, lengthening of the cord, and then when you push the uterus up, the placenta doesn't move. These are the signs clinically to know that the placenta has got separated. Types of placental separation, I think all of us have learned Matthew Duncan and Schultz method of separation. This is from sideways, placenta gets separated, starts at the edge of the placenta, slow and delayed separation entire, and the bleeding will be little less here. Bleeding is more because it separates slowly so that uterus cannot contract effectively at once, and the no retroplacental clot to separate the placenta. Whereas here, retroplacental clot is there in the Schultz method. It separates the entire placenta and it comes out as a discoid, it just comes down. A gush of blood after placental delivery will be there because as it separates at once, there will be a bleeding there that will come out. Now, the signs of stages of placental delivery, descent of the placenta from the fundus. First is the separation. We spoke about the separation. Descent of the placenta descent into the lower uterine segment and even into the vagina. Uterus contracts. The pressure exerted by the retroplacental hematoma and increase in the maternal abdominal pressure also. This is the time when mother tries to push out the placenta. Expulsion, spontaneous, when the mother has the urge to push something, she pushes, then the placenta will spontaneously deliver without any assistance or the manual delivery of the placenta. What usually we do that because it will take time otherwise for the spontaneous delivery. And how do we deliver the placenta? How do we manage the third stage of labor? That's a type of placental delivery. One is expectant, One is the active management. This is very important, active management. I'll come to that. What is physiological management or expectant management? Now, no routine use of uterotonics. That means we don't give any drug which will contract the uterus more. You allow the uterus physiologically to contract. With that, the placenta gets separated. Wait for the signs of placental separation. Always we used to say, fold your hands, watchful expectancy, they used to say, for the second stage of labor. Same thing we always ask the juniors because they tend to meddle with the cord and try to pull. We used to tell them, fold your hands and keep away. So look for the signs of placental separation, which we saw in the previous slide. Wait for the spontaneous expulsion of the placenta. That will take a long time. During that time, probably uterus may be not very effectively contracted. So little bleeding may be there. Bleeding is more especially. Yes, that's why, because it takes time to deliver the placenta. Otherwise, what we could do, we can just, once the signs of separation we have seen and waited for 2-3 minutes, placenta has not been spontaneously expelled, then give a suprapubic bimanual expulsion of the placenta. It's called bimanual. One hand you hold the card and try to give a pull. With the other hand, suprapubic push to be given so that uterus should be pushed away, not down, but pushed away, so that this is called traction and counter traction, which we use very much in the active management. So when you do that, the placenta will come down. Why this counter traction on the abdomen is to prevent the inversion of the uterus. So this is the physiological, actually physiological management. You don't need to do anything, wait and wait and wait until the spontaneous expulsion. Sometimes what happens is placenta will come down into the vagina, it will not get delivered. And unnecessarily there will be bleeding. So probably you may have to remove the placenta from this. Give a traction on the cord, the placenta will come out. Now the active management, this is very, very important now all over the world. Active management of third stage of labor is recommended because it's very effective in preventing the postpartum hemorrhage. 70% of the postpartum hemorrhage can be prevented just following the steps of active management of third stage of labor. Unfortunately, whoever postgraduates I meet, I'll ask them in the labor room, what is the active management of third stage of labor? Nobody will tell it correctly. That is the state of affairs even now. This has come into vogue for many, many years now. Routinely in every labor room, probably we need to have this active management of third stage of labor. It's called AMTSL. Okay, what do we do? This is against the spontaneous or physiological delivery. Here we use the uterotonics. The prophylactic uterotonics is given. What are all the uterotonics? I'll come. Usually what we give is oxytocin. Okay. So this is the one which is recommended all through by WHO, uterotonics. If it is not available or it is not effective, something else also you can use. But usually oxytocin is a very, very effective uterotonic which can be used. Now what do we do? After the delivery, at the anterior shoulder, delivery of anterior shoulder of the baby, or as soon as the baby is delivered, give oxytocin 10 units IM or IV we don't recommend, and usually we don't give because sudden drop in the blood pressure can happen if we give. So instead of that, safest will be oxytocin IV. Sometime there was a recommendation for intra cord, into the umbilical cord, we used to give the oxytocin 5 units. That used to be very effective, they say, for the separation and even prevention of the PPH later. But that has got very few, a short period it remained, and afterwards now it is not practiced. But what is practiced now? As soon as the anterior shoulder you deliver, tell the sister. Now in the labor room, sisters are so used to that. As you are delivering anterior shoulder of the baby, they give off IM oxytocin. When you ask them, Madam, already we have given at the anterior shoulder. Now, initially we used to say immediate cord clamping. But now the cord clamping is not immediate. Wait for 1 to 3 minutes. They say we regularly wait for whether it's a cesarean, whether it's a normal vaginal delivery or assisted vaginal delivery. unless the baby is very sick and needs a resuscitation by the neonatologist, what we do is we wait for the cord clamping. That helps to prevent 70% of neonatal anemias will be prevented by delayed cord clamping. Everybody must practice this. If the baby is healthy, a neonate, is healthy, 1 minute to 3 minutes. I usually wait for 1 complete minute, 60 seconds to delay the cord clamp. After that only we clamp the cord. In that 60 seconds, lot of blood will go from the placental side to the fetus, which will prevent anemia in the fetus. That's very, very important. Now, next is the controlled cord traction, which I have shown the previous slide. How do we do? One hand on the suprapubic region, the other hand holding the cord. Traction and counter traction we give. And this, before this controlled cord traction, one thing we have to be very sure is palpate the fundus of the uterus, and the fundus should have contracted very well. Sorry. In any case, uterus has not contracted, we don't pull on that because inversion can occur easily. Because we are not here, the main difference is, one is we are giving oxytocin. Second one is we are not waiting for the signs of placental separation. That means in the spontaneous we have seen, wait for the cord length, lengthening of the umbilical cord, extravalvular lengthening of umbilical cord, abdominal uterus becomes tight, and then the size increases, all, and a fresh bleed. All this we are not waiting. The moment the baby is delivered, just palpate the uterus. Uterus is contracted, give the traction and counter traction to deliver. Now, after that, uterine massage after delivery of the placenta. Why this has come into vogue is, in a corporate hospitals or in a city, the nursing homes, it all available, this can be done. In a rural setups, we may not have all the facilities. So to suit them, now what has happened? These are all the components which were there. 1, 2, 3, and 4 components were there. Now, the WHO says most important is giving the oxytocin. Other 2 components are optional because the nurses will be delivering in the villages or in a PHCs. They may not be able to do the uterine massage, they may not be knowing it. And then controlled cord action, yes, they may not be able to do correctly. So what is most important is giving oxytocin. If they are trained, yes, controlled contraction, which will shorten the duration of the 3rd stage of labor, and it also prevents the bleeding, more bleeding. Uterine massage is become optional if the uterus has contracted, because we have to see at this level whether the uterus is contracted or not. If the uterus has contracted well, we don't need to do this step. The postpartum monitoring of the uterine contractions every 15 minutes for next 2 hours, and if necessary, uterine massage. So uterine massage, routinely we needn't have to do, but definitely we have to do if the uterus is in between relaxing for the next at least for 1 hour, we have to observe. And before this procedure, we have to make sure that urinary bladder of the patient is empty, because if the bladder is full, the uterus will not contract and patient will be bleeding. So 3rd stage of labor, when we come, maybe first, even 2nd stage, if it is so, bladder gets unnecessarily compressed when we are delivering the baby. So we see that at the end of the 1st stage, when we are delivering the baby, we make sure that the bladder is empty. If suppose we miss that, we have to be very sure in the 3rd stage, the bladder should be empty. These are all the small precautions we need to take. They go in a long way for preventing the postpartum hemorrhage. Now, the drug I wanted to take, I said about the oxytocin is the drug of choice. Yes, because it is cheap, it's available everywhere, and it's very effective. But having said that, there's recently now one more molecule has come into the market, and it is, advocated very seriously because it's more effective than oxytocin, they say, that is carbetocin. Carbetocin is a synthetic analog of oxytocin and the long acting and heat stable. This is very, very important for us because oxytocin has to have a cold chain. Even when it is transported, suppose you have a pharmacy and you want to buy oxytocin. From the dealers, you have to get the oxytocin, it should come in the cold chain. If I have to take to my place or to the labor room, always it has to be kept in the fridge. Support the current fluctuation, electricity fluctuations are there, and it is not very effective. You don't have the system where the uninterrupted electricity supply is there in the labor rooms. This potency of the oxytocin comes down. Many a time we struggle saying that there is a PPH, we have given oxytocin, it's not helping, it is not taking up. Why? Because the potency of oxytocin would have come down. Transient in the transport, in the storage system, in many places it may lose potency. So that with the carbetocin, we don't have this problem because it is heat stable carbetocin now. This is the most advantageous this one quality of this drug. So it is 100 micrograms IV or IM can be given. Its half-life is 30 minutes. Now it binds to the oxytocin receptors and increase the calcium influx. See, this is again another important thing, so that when there is a calcium influx into the cells, automatically it contracts. So what happens is smooth muscles of the uterus start contracting effectively. Increased frequency of existing contractions. If the uterus is already, we saw, as the placenta has to separate, uterus starts contracting. If there is already existing contractions, it increases the uterine tone and more effectively uterus starts contracting. That means equal to for us, the bleeding will be less. The sustained uterine contraction starts in 2 minutes after IV injection and remains for 6 minutes. Sustained contraction. After that, rhythmic contractions will go on for next 1 hour. Whereas oxytocin has got a half-life as only 15 minutes. After that, its effect may not be there. After IM injections, is sustained contraction for 11 minutes and rhythmic contraction goes on for 120 minutes, that is 2 hours. So 1 to 2 hours, our fourth stage of labor, if we could have given one carbetocin at the delivery of the placenta, next 2 hours we are safe that there won't be any uterine relaxation and bleeding may not be there. The safety profile is similar to that of oxytocin and side effects are also same. Nausea, vomiting, abdominal pain or sweating, dizziness, this can happen. But usually though they say that usually the dose what we are giving is only 100 micrograms and it's only single dose. Whereas oxytocin, what we do, we give the bolus, we put 20 units into the drip and we run the drip. Carbetocin is not done that. Only one dose is enough. No need for additional dose. That's it. As whereas oxytocin, we need a drip infusion for next 2 hours. That is not needed with the carbetocin. It prevents PPH after both cesarean and vaginal delivery, used for prevention and treatment of PPH. Then contraindications, cardiovascular disease, cardiomyopathy, asthma, migraine, and epilepsy. If the patients have got this, we have to be very careful. We should not give IV at all. Maybe carefully we can use IM injections. Now, what is the advantage? I mean, carbetocin versus oxytocin. Oxytocin is time-tested drug. For many, many decades we have been using it. Oxytocin at a heat nearby and needs a cold chain to maintain the efficacy. Myometrial contraction it brings in, of course. 15 minutes is the half-life, so needs a continuous infusion. After 15 minutes of one injection, uterus tend to relax if at all it has to. So it needs a continuous. That's what we do after delivery. Bolus at the third stage of labor. After that, next 2 hours, we put in a drip fashion oxytocin 20 or 10 or 20 units, and we will be running it. The same side effect, loss of appetite, nausea, vomiting, cramping, water retention and hypotension, because it's a posterior pituitary hormone. So it has got the effect, posterior pituitary effect, hypotension and water retention. sometimes need other oxytocics to arrest bleeding. If they go for a PPH, we need an additional oxytocics to arrest the bleeding. Whereas carbetocin, as we said, heat stable, maintained efficacy at the room temperature is the most advantageous thing. Probably in our primary health centers and the rural places where we can use this, where there is no electricity, we don't have a fridge to keep all these things. So probably we can keep at the room temperature. That's the most advantageous thing of this drug. Then bilateral contraction is the same mode of action, 60 minutes after IV, 120 minutes after IM. So much so that we don't need any other oxytocics. But the side effects are same like the oxytocin because it's only again oxytocin derivative. Now, these are the other oxytocics. I've been telling oxytocics. What are the other oxytocics we have? We don't go into it. It's a busy slide. We don't go into the details. But what we have is oxytocin I spoke about, which is used now. Carbetocin is taking over, and it's many places they use carbetocin. And this I just spoke. Then methergine is gone away from the labor rooms now. Very rarely we use methergine. When there is a postpartum hemorrhage, we use methergine. Otherwise, we don't use methergine at all because a lot of contraindications are there for this, like hypertension, heart disease, preeclampsia. So many the contraindications. So we slowly methergine is given away, and then instead of this, carbetocin has come. Then symptomatin we don't have in our country. That is combination of oxytocin and ergometrin. We don't have and we don't use this. Then misoprostol. This is the other very, very effective drug which could be used as a prophylaxis for PPH. What I do is routinely 400. This is again, we don't need to have a cold storage. It's a tablet, not even an injection. In a primary health centers and all, probably if they don't have injection, if the person is not able to give IM or IV injection, best thing now WHO is recommending every patient, a pregnant lady has been given a misoprostol 2 tablets to keep with her and bring it when she is coming for labor. So that as soon as the baby is delivered, put this tablet sublingually. It will act within 3 to 5 minutes. And its duration of action is 1 hour and all, 1 to 1.25 hours. So that effective uterine contractions will occur. But only complication is shivering and then little temperature, the patient may get it. This is usual, but doesn't matter, it will be self-limiting, it will subside by itself. Now next is the carbopras. This is injection. This is the prostaglandin, 250 micrograms. It is also again very, very effective. This we use when there is a postpartum hemorrhage. Routinely we don't use for the prophylaxis of the third stage because the one is the cost, other is the side effects. Lot of side effects, especially diarrhea is the nuisance we'll have with this drug. So we don't use routinely for a prophylaxis. For the prophylaxis, what we could use is these two drugs, or what I use is misoprostol sublingual. So this can be used as a prophylaxis, but carboprast cannot be used as a prophylaxis because of various reasons. We use this when we have postpartum hemorrhage. It's very effective. I give intramyometria. That means directly, not systemic. Systemic we can give IM. It is not IV. We can give IM, but I give usually intramyometria. Onto the uterus muscle we give so that immediate contraction of the uterus occurs and the PPH will stop. Okay, methods of placental delivery. Creed's method, which is abandoned, which no more we use because we used to have inversion of uterus. See that how it is. The fundus uterus is pushed down, and with the other finger, the cord is pulled down. So what happens along with the placenta, if it is not completely separated, what happens? Even the uterus comes down. So the chance of inversion was there in that. See, that's why the Creed's method is abandoned. Now what we have is Schultz method, Brand-Andrews technique. This Brand-Andrews technique is again, uterus is contracted. We see that uterus is contracted. We saw in the spontaneous placental delivery how we deliver. Elevate the uterus suprapubically, push it up uterus, pull it down on the cart. This is Brand Andrews technique. This is very safe and it will not cause inversion of the uterus. Placenta is separated. Wait for the placental signs of placental separation. Firm traction is applied to the umbilical cord with one hand, while the other applies suprapubic counter pressure. That is the Brand Andrews. Usually we do this method of placental delivery. Now, of course, it is active management. Now, after that, what should we do? This is, immediately the placenta goes into the dustbin. It should not be done like that. I always teach all our students, how do we hold the placenta also, we tell them. Hold it in both hands like this and look for the cotyledons. See, this is the maternal surface. These are called the cotyledons. Sometimes what happens is one cotyledon will be missing inside and patient will have PPH after that. We won't be knowing it because we have thrown the placenta into the dustbin. If only we inspect the placenta, we know if there's any missing cotyledon, immediately we know we explore the uterus so that the PPH will not occur. If we don't do, sometime one of the cotyledon, maybe the central one usually happens to us. All this periphery gets separated, but the central one may be there. Patient will go on bleeding it. You won't be knowing why. If only we inspect the placenta routinely, we know the cause for the PPH would be this. This is the fetal surface of the placenta where the cord attachment, where the cord is attached. Sometimes cord will be attached here marginally. So this you look for, and the membranes also we have to look for. Along with the cotyledons, the membranes which are covering this amnion and chorion, and you have to see the membranes are tapering and they are there. The next thing what we have to observe is take the edge of the cut end of the umbilical cord and look for 3 vessels. 2 arteries and vein have to be there. Okay, this is the normal. Now we know because of the ultrasound, even in the second trimester itself, they will say if the single umbilical artery is there, the sonologist would have reported it single umbilical artery, because sometimes with the single umbilical artery, the baby will have a lot of problems. I had one or two babies who couldn't thrive and who succumbed to that. Okay, so it is very important to note the umbilical. I mean, we used to make a note in the delivery notes. Umbilical cord contains 2 arteries and 1 vein. This is the way how. Okay, then maternal surveillance, what do we do? Uterine fundus is assessed for its contractility. Vagina is to be inspected for tears, definitely. Cervical tears can be there, even though it's a normal vaginal delivery. Sometimes cervical tears can be there. If we miss to see it, probably she will continue to bleed. Then we have to re-explore her. If episiotomy is given, wound to be sutured in layers. Then periodic assessment of uterus for its sustained contractile state for the next 1 or 2 hours, as I told you, and vitals to be monitored after delivery. Why we need to do? Because a lot of complications can occur. Now, what are those complications? Obstetric shock is the one which is really a shock to us. Suddenly, she will go into shocks. If you remember my first slide, a normal delivery can turn into disaster. Why the disaster? It could be amniotic fluid embolism. You have no time to resuscitate. I lost one patient like this. That's all. In minutes, we lose her. Or it's an obstetric shock, or it is the postpartum hemorrhage. Dreadful complications. Within half an hour or 1 hour, if you can lose the patient very easily, a normal delivered patient, if these 3 things happen. Obstetric shock, or of course, obstetric shock may not be, you have some time to resuscitate her, but amniotic fluid embolism and postpartum hemorrhage, if you don't attend to that immediately, within an hour's time, we can lose the patient. A PPH, then retained placenta. Placenta got separated, but it is not coming out of the uterus. It can be, that is called retained placenta. Placenta could be retained in the uterine cavity, lower uterine cavity, or even in the vagina. We need to only just pull it out and see, it may come out. Then adherent placenta. This is another dreadful complication. Now, if at all we know that antenatally the placenta is adherent. Please remember, those patients have to be delivered in a tertiary care center. Nobody can take these patients in nursing homes to deliver. We lose the patients very easily. So adherent placenta is the other one, which is a complication. And then, of course, inversion of the uterus. That's what I said all the time. Make sure that uterus is contracted before you give a pull on the cord. If we don't, just uterus is not contracted very well, you give a traction on the cord, uterus will come down and the inversion of the uterus occurs. Patient will immediately go into shock. So this is again another iatrogenic emergency. This will be because of our carelessness. We are doing this emergency. These are, of course, birth canal injuries. There will be bleeding. That's all you can visualize nicely, and we can suture them also. So active prevention of complications, active management of third stage of labor, anticipate the complications like in over-distended uterus, that is a multiple pregnancy, big baby, there's an abruption and you are delivering, there's an anemia, very little amount of blood loss, also she can go into hypotension. So all these things you have to take into consideration when you are delivering the patients. PPH can happen in all these patients. So we have to be very, very careful. Liberal use of oxytocics if indicated. Close surveillance in fourth stage of labor so that we don't miss the bleeding, we don't miss obstetric shock, we don't miss other complications. So third stage of labor is most important as it can lead to many complications, even causing the life of the patient. So stitching time saves life. That's what they say, golden 10 minutes. Golden hour we used to say. Now we say golden 10 minutes for the postpartum. Thank you all for your patient listening.
Thank you so much, ma'am, for your wonderful presentation. We do have some question if you'd like to take that up.
Please, you can.
So, ma'am, the first question is, what are the recent advancement in the management of third stage of labor and how they have impacted clinical practice?
I told no, active management of third stage of labor, using of carbetocin and the oral sublingual misoprostol, these are all the advancements, which is bringing down, I said, 70% of the postpartum hemorrhage we can prevent by these simple methods. That's a great thing for us because most of the maternal mortality all over the world, mostly in India, is because of the postpartum hemorrhage. So that if we can prevent to the extent of 70%, it's a real advancement.
Thank you, ma'am. The next question is, how should potential complications be communicated to the patient and family members?
Yeah, whenever I showed, no, the patients who are high risk for the postpartum hemorrhage, all of them have to be counseled regarding the probability of going in for complications. And we have to keep, our team should be ready for that. The patient should not be told so much because she will be terrified. Okay. But the relatives have to be told about it. There is a possibility that she can go in for postpartum hemorrhage. Okay, so we'll ask them to have some donors. Though we'll arrange blood from blood banks, but in small hospitals, they don't have a blood. Like Ramaya, I have a blood bank and I'll ask them, they'll give any group of blood, but it may not be. So what they have to do is, all these high-risk patients who are going to have probable complications, we have to tell the relatives to have donors. Even if they are okay with donating 1 unit of blood to be kept in hand, yes. And afterwards, they should not come and, usually they come and, you have not used the blood. And what do you do? It's okay, you donated a blood. It's a novel thing you have done in your life. They don't take it like that. Doctor, you have taken blood, no, give it off to my patients. Luckily, she didn't need the blood. She has no complication. Be happy with that, we say. So there will be a problem with the relatives, but always you have to tell them to keep their especially negative groups and AB group of blood. If the patient has, we have to tell them to get some donors. If they are okay donating the blood, yes, donate and keep the blood ready. And of course, other drugs and all we have in the hospital. Suppose if the nursing home or a small hospital, they don't have, get the drugs like carbetocin, is a little costly. we can get and keep it in our labor table. And
Thank you,
taking
ma'am.
consent.
Yeah.
Informed consent has to be taken in case there is any emergency. We will be accordingly managing the patient. That may include blood transfusions, OT, manipulations. All this we have to take a consent from the relatives and from the patient for delivery and interventions. And we will take consent usually. All that is important.
Thank you, ma'am. There's one last question. How does the management of the third stage of labor differ in case of multiple birth or cesarean section?
Cesarean section, third stage of labor, uterus is in your hand. You deliver and then wait for the cord clamping. You wait for 1 minute even on the table, separate the baby, allow the placenta to separate, and then everything is open there, uterus is open, you are looking at it with your own eyes. So you can remove the placenta and then suture the uterus. Here in the vaginal delivery, we are not, but the same principle we follow. Delayed cord clamping. Okay, spontaneous expulsion of the placenta. We don't manually remove the placenta because we are accessible to that. In the uterine cavity, few people, what they do as soon as they deliver the baby, they put the hand and separate the placenta and take it out. So that they suture off the uterus and to shorten the time of cesarean section. But usually ideal would be wait for the placenta to separate so that uterus would have contracted. The bleeding will be minimized even during cesarean section. Okay, that's all we need to do.
Thank you so much, ma'am, for answering all our questions. So, ma'am, before concluding, any last remark from you?
I think I don't know. Actually, you know what the pity is? I don't know the audience. What group of audience I have, I don't know. Is it a gynecologist? Is it a general practitioners? Or is it some other people? I don't know. You have not told me the
Uh,
audience.
Ma'am, we have mixed audience, so both the practitioners, doctors, and general public as well. So you can give any take-home
So
message.
general public is always they go to the doctors and listen to the doctors, whatever they say. And you have any questions about it, please ask, clarify your doubts rather than blaming the doctors afterwards. There's a one thing is the delivery, especially third stage, is very, very unpredictable thing. Everything goes normal. Suddenly patient starts pouring out PPH. We have so many times we experience this. And people start blaming us, saying that everything was normal. Why you have done some mistake? So the patient starts bleeding. It's nobody's hands. It is. So that they should understand. For the public, it is. For the doctors, yes, if there is any high risk, please use the tertiary care centers in the beginning itself. Don't shift the patient after delivery with the complications. So always choose and then correctly judge the problem. Suppose there's a multiple pregnancy. There's every chance that she would bleed. And you need to have two pediatricians to resuscitate the babies. You must have two obstetricians so that any emergency they can help each other. If you don't have those facilities, always you admit them under you in some corporate, a tertiary care center. I don't say corporate hospital, but tertiary care center where you like Ramaya teaching hospital we have, medical college attached hospital. That's not a corporate hospital, but still we have everything. So in such places, you admit your patients and take care of the patient properly. Safety of the patient is very, very important. And anticipation is the most important thing for us. Which patient would possibly go for complication? You anticipate and be ready. In my experience, vast experience of 45 years, I am telling, if you anticipate, you are ready with every possible probabilities and to act for that, it will go very smoothly without any complication. If you just say, oh, nothing will happen, you get into the problems. Once you get into the problem of PPH or an obstetric shock or an amniotic fluid embolism, that's the end. It will be very, very difficult to bring out the patients from that. So we have to anticipate and accordingly we must act. That's my,
Thank you so
summarizing
much.
statement for all the professionals.
Thank you so much, ma'am, for your wonderful insight, ma'am. And with your permission, ma'am, I would like to conclude